Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
Hello, I'm Judy King, Consultant Medical Oncologist at the Royal Free Hospital and Barnet in London, UK. Welcome to this programme titled ADCs in Practice, Contemporary Questions for the Treatment of Hormone Receptor Positive, HER2-low metastatic breast cancer. Joining me today are two colleagues of mine, Giuseppe Corigliano, who is Professor at the University of Milano and is Director of the Division of Early Drug Development at the European Institute of Oncology in Milan, Italy, and Peter Schmidt, Professor of Cancer Medicine and Clinical Director of the Breast Cancer Centre at St Bart's Hospital in London, UK. Welcome both, and thank you for joining me for this discussion. So just to start off, I think we're all very well aware that the current landscape for antibody-drug conjugates in metastatic breast cancer is now very, very busy. What has started with the initial introduction of TDM1 for HER2-positive metastatic breast cancer and was really a drug out there on its own for a long time. We then had the introduction of TDXD in HER2-positive breast cancer in that metastatic space, but more recently we've had a huge expansion of antibody-drug conjugates with different targets, different payloads, and those data have been positive now across the board into triple-negative breast cancer and then HER2-low, unselected ER-positive or the ultra-low. So we've really had a huge expansion across the board and big differences in terms of the ADCs themselves, with changes with regard to the drug to antibody ratio, different linkers, which has led to what we call the bystander effect, as well as that classical mechanism of action. And while that has led to, by and large, much better efficacy, it also has brought with it increased and different toxicity. And so these are all things that we need to bear in mind when we try to introduce these drugs to the clinic, because as the results come through with each passing congress, we don't often have one drug pitted against another, and so that space is becoming ever more competitive and being more complicated, perhaps, to interpret where we should put these drugs as they develop newer targets, newer payloads, and so forth. So I think one of the main questions is when to give these drugs. Certainly in HER2-positive breast cancer, for example, where it all began, the mantra has always been give the best drug first, because we know that there is a certain level of attrition with some patients who start in the first line, don't get to second line, and certainly don't all get to third line. And so that idea of really getting the best drug in at the first opportunity has been very much the mantra that we've lived by as oncologists. However, as we look to a move to HER2-low, or which is largely ER-positive breast cancer, that's a very different disease. It's also a very much broader church. And where those things are true, does the mantra stay the same? So we're going to have a discussion about that first and look at the data for first line versus second line. And then later and Giuseppe Corigliano is going to lead that discussion. And then we'll bring in Peter Schmidt to have a wider discussion about maybe the data-free zone, some of the unknowns, really. So what do we know or what don't we know about what to do after the ADCs? What about sequencing one ADC after another? What about the different toxicity profiles? So a lot to discuss. Let's see what we can get through. And I'll hand over at this point to Giuseppe, who's going to talk about that question of, in that HER2-low space, should everyone have first-line treatment, or is second-line treatment still a relevant option? Thank you.
Oh, thank you very much for the introduction. I just would like to remind the data of the Destiny 4 and the Destiny 6 before answering this question. So, in the Destiny 4, patients with HR positive HER2 low disease have been randomized after 1 or 2 lines of chemotherapy to trastuzumab deruxtecan versus investigator choice treatment. The median follow-up was almost 3 years, actually, and the treatment with trastuzumab deruxtecan improved the median progression-free survival from 4 months to 8 months in the last follow-up, with also an improvement in overall survival. So the question was whether we can anticipate the use of trastuzumab deruxtecan in those patients who never received chemotherapy, so pure endocrine resistant, after 1 or 2 lines of endocrine therapy. And that's why the Destiny 6 was designed as a prospective randomized trial for patients with their too low and their too ultra low disease, comparing trastuzumab deruxtecan to standard chemotherapy. What we demonstrated is that if you anticipate trastuzumab deruxtecan, you can improve the median progression-free survival from 8 months to 13 months, with the trend of positivity for overall survival, but we need a longer follow-up. In terms of response rate with trastuzumab deruxtecan was 57% versus only 30% in the chemotherapy arm, with a safety profile that is almost attended from trastuzumab deruxtecan. And the similar benefit was also observed in the population of HER2 ultra low, with an improvement of median PFS from 80 months exactly to 13 months. So why anticipating trastuzumab deruxtecan? After progression to 1 or 2 lines of endocrine therapy, some patients with indolent disease, with bone-only asymptomatic disease, for sure they can receive first chemotherapy. But for any other patient with visceral disease, at least according to the guidelines, we should test for the level of HER2 expression, and we should consider eventually the opportunity to anticipate the ADC, because we know perfectly that no single chemotherapy can impact on overall survival, and we still need to see the data of Destiny 6 in terms of overall survival benefit, considering that the majority of the patients in the Destiny 6 did the crossover to TDX in the control arm. So the discussion that now we have to do, and I would like to engage also Peter, is first, do you believe any single patient should receive an ADC after 1 or 2 lines of endocrine therapy? Second, which is the balance between cost in terms of toxicity and activity, and what you do in your practice. Who are the patients that you will candidate directly to an ADC, and those for which you believe you need to do a chemotherapy before?
Yeah, so I think, Peter, I'd like to bring you in on this. I think it's a really tricky one. And I think that, I mean, for some clinicians, the choice is made for you because of the financial reimbursement constraints. But I suppose, irrespective of what the finances say, you should really have an idea clinically of what you would do if you could, rather than what you are only allowed to do. And I think that the difficulty for me is that when we talk about endocrine resistant patients, we really do have a very broad group of patients. Like if you look at, for example, the PIK3 kinase mutant patients who can go very rapidly, and you'd be thinking, absolutely, I'd want to use an ADC first line here. Whereas there's those other, maybe the postmenopausal women, they've got slowly progressive disease and they eventually develop a couple of new lung mets, and you're thinking, actually, you know what, from a quality of life point of view, I've seen a lot of these women do very well on, oral capecitabine, for example, for a very long time. And it's about maintaining, because I do think that when you look at the toxicity data, TDXD is tough to maintain the dose intensity. Peter, what's your practice?
Yeah, I think it's a difficult question. Ultimately, I don't think there's one strategy that fits all patients. And as both Giuseppe and Judy, you're mentioning, we have to look at the patient in front of us. The first thing for me is I would only consider patients who are hormone refractory rather than just hormone resistant, because we have obviously now multiple combination endocrine therapies that overcome some of the resistance. But once patients are refractory, then we have to move on to chemotherapy. These ADCs, and TDXD is one of them, are chemotherapy, although a targeted form of chemotherapy, but I would still classify them under a group of chemotherapy. And of course, when we choose between different chemotherapies, we have to make choices. There are some patients with very indolent disease who may actually be very well treated with an oral chemotherapy like capecitabine with very limited hair loss and can have the disease very well controlled. On the other hand, you may have patients who are very aggressive, possibly impending visceral crisis with multiple liver and lung metastases, where you probably want to choose the treatment that has the highest chance of response, and that is in this situation TDXD. And one of the things you said right at the beginning, do we choose the most effective therapy first? And I think that's a difficult decision. If you look at the delta between the control arm and the TDXD arm, and both in DB04 and DB06, it's relatively similar. If you look at the response rate in a second-line setting, and it's one of the things that has been impressing me and fascinating me about the ADCs, is there's this substantially higher response rate we see even in pre-treated patients, where it becomes more relevant often. So I don't think the answer is that every single patient should get an ADC or should get TDXD as a first-line treatment. But some of those patients really will benefit from it, and other patients will benefit from second line. There's a point I want to pick up, Judy, you mentioned, and it's about toxicity. One of our learnings is really that the better the team is experienced with using ADCs, the lower the toxicity, the better the tolerability. And I think we feel now that patients have a much better quality of life these days with sacituzumab govitecan, with TDXD, when we treat them, compared to 4 or 5 years ago, where we as a team weren't as well versed in preventing and managing toxicities. So I think it is now possible to give those treatments for many years. I don't think there's a substantial difference anymore between ADCs and most of the chemotherapy regimens in terms of tolerability. But of course, we need to select patients on an individual basis to whether we go in with an ADC first or with, for example, oral chemotherapy such as capecitabine.
Yeah, I think that there's certainly there are implications not just for the patients in terms of the toxicity, but also for the wider system. And so, giving an IV treatment, that is a burden on patients, but also on hospital resources and so forth. I mean, Giuseppe, do you hear much about the sort of recent changes with the HER2 testing? And I think that are there different issues across Europe in terms of identifying those HER2 low patients?
But, personally, I believe if we check the data of the Destiny 6, if you remember in their 2 ultra-low cohort, the central testing was redone to evaluate the opportunity or not to identify those patients by local testing. And what we discovered was that there was a discordance rate around 20% for their 2 ultra-low population, increasing to 30% for their 2 ultra-low population. So it means that there is still a problem in identifying too low and ultra-low in the local level. So what is really essential is that pathologists are trained to better test the liver over 2 in the local testing for too low, and most importantly for too ultra-low. I believe in the future also artificial intelligence may help us, because the cell visual analysis testing, of course, and the use of digital pathology will improve eventually the number of patients that can be eligible, of course, to trastuzumab deruxtecan therapy.
Yes, you remind me that actually there was quite a big fallout, wasn't there, in DB06 between the patients screened and then the patients who went into study because of that central testing for the HER2 low, and it was quite a marked proportion of patients that didn't follow through. So I think certainly there's going to be, it's not just the the chemo suites, but also the histopathology implications we shouldn't overlook. What's your practice locally? Do clinicians tend to go for first line TDXT in this setting, or do they go for other ADCs, or do you find that the practice is quite mixed?
Usually the practice is quite mixed. And as I said before, patients who will go directly to an ADC are endocrine and refractory, as Peter said already.
Yeah. I mean, I think it will be interesting as well, as you mentioned, there are so many more drugs and combinations coming through in that endocrine space, and what that will mean for the phenotype of the cancers that comes through at the other end will be interesting too. Well, if we move on then to discuss maybe some of the other antibody drug conjugates which are available. Peter, if I can maybe ask you, that there is data for more than one ADC in this ER positive space. How do we pick which one to use? What do we think about ADCs on progression? Some thoughts.
Yeah, it's a really important question. There's essentially two questions you're asking: is what other ADCs are out there, but also what do we do on progression after trastuzumab deruxtecan? Whereas the first question is relatively easy to answer. We have at the moment two other approved drugs targeting TROP2, but a similar topoisomerase 1 payload. So one of those is called Dato-DXd, the other one is called sacituzumab govitecan. And both drugs have shown substantial activity in phase 3 trials. If you look at the sacituzumab govitecan data, this was a trial in patients with predominantly in third and fourth line setting, with a small percentage of patients in second line setting. So more heavily pre-treated than patients in the DB04 trial Giuseppe mentioned earlier. It showed a significant benefit of sacituzumab govitecan over treatment of physician's choice with a hazard ratio of 0.65. But of course, the overall, the absolute benefit in PFS is much smaller. And that benefit also translated into an overall survival benefit. We have seen from analysis that TROP2 expression does matter, but only to a certain degree, because standard chemotherapy is actually quite inactive in this setting. We learned that patients with high or low TROP2 still had a better outcome compared to standard chemotherapy. But patients who have a higher TROP2 expression do ultimately better. And that's not a surprise. We see the same with HER2-targeted agents. If you have higher HER2 expression, you have a better response with trastuzumab deruxtecan in HER2 high compared to HER2 low. We have similar data with a second drug, Dato-DXd. Again, that trial was a little bit earlier in line. There was predominantly a second line treatment, again, versus treatment of physician's choice. And most importantly, in both of these trials, patients were not pre-treated with other ADCs and not with the topoisomerase 1 payload ADC. And again, Dato-DXd showed a substantial benefit in terms of progression-free survival, did not hit overall survival at this point, but it was still sufficient to be licensed and available for patients. One of the key questions, how do we select patients, and what drives ultimately resistance to ADCs? And I think if you look at the data with TDXD, a lot of clinicians feel out that is probably your treatment, your ADC of first choice in ER-positive breast cancer. So when we consider what do we do afterwards, we have to think of what would have driven resistance to ADCs. And in a nutshell, it is two possible main mechanisms. One is resistance to the payload. The other one is resistance to the actual target. And what we seem to be learning is that resistance to the payload is probably the more important and the more frequent a driver of resistance in this setting. We know that the target can change relatively quickly if it's not genetically imprinted, as we see with HER2 low, but nevertheless, most patients will have acquired some form of payload resistance. We've also learned that this resistance is often subclonal. So if you have 10 sites of disease, 1 may be progressing, 9 are still responding, and in that situation, we often vertical progression bring in localized therapy. So how do we put all of this together? Would you consider Dato-DXd or sacituzumab govitecan after trastuzumab deruxtecan? The answer is yes, we can. And we have some limited data from some real-world experience studies that show there is still activity seen. But in a nutshell, I would expect that activity probably to drop to around a third of what we see in patients who haven't had a topo-1 ADC beforehand. And so our priority in the future, in my opinion, needs to be to find non-cross-resistant payloads rather than just looking for different targets, because one ADC after another with the same payload may work in some patients, but probably just in a limited number of patients.
Yeah, that was that really interesting data where they showed within the same patient, the subclones which might be resistant to some of it's because of the payload and some it's because of the target. And that does feel like it's going to make it more complicated. And where is the role for going in with a standard line of chemotherapy, for example, rather than having to faff around with all these competing mechanisms of resistance? Giuseppe, do you have any comments about this fast-moving data-free zone?
This is an important question. What we know from real-world data is that if you sequence ADC1 and then ADC2, the median progression-free survival of ADC2 will be shorter. There are several reasons maybe to explain why. First, the cross-resistance on the payload, because finally the majority of payload are topo-1 inhibitors, or potentially also a mechanism of resistance related to the target. So this is a very important question. And the comment I can do is whether we may consider to do a sandwich between one ADC and another one with another type of treatment that can be a standard chemotherapy. In my opinion, the design of future clinical trial should consider median progression-free survival too. So for me, an ideal trial should be to treat one patient with an ADC and then at progression with a secondary ADC, and to compare finally a sequential strategy versus eventually a sandwich strategy, because we really need to understand which is the potential impact of the second ADC on the median progression-free survival too. Or eventually, you can design trial in which you alternate one ADC versus another one. And there are some trials ongoing in which they deliver first an ADC, then another ADC, and they alternate one versus another with eventually not cross-resistance payload or with a different target antigen. So this is the main question for the future. What we know from the neoadjuvant setting, and we will see this data at ESMO this year, is that if you sequence an ADC with the chemotherapy, the impact on the rate of potential pathological complete response in the adjuvant setting is better. So it seems there is still a role for chemotherapy in the sequencing of an ADC with another treatment.
Yeah, I think that that neoadjuvant data is going to be really interesting, where studies, where people go from one option to the next to see if they. And I think that looking at the PathCR as a sort of a surrogate will really be informative in terms of what we do in the metastatic setting. And I suppose on a basic level, is the take-home message for clinicians that if we are using ADCs after another ADC, is just that awareness that is not how the trial was run, and so you cannot be promising the same degree of benefit. You just need to be aware of that when you're sort of balancing up the risks with your patients. I suppose, Peter, if we just sort of come back to this sort of concept of risk and patient selection, are there, when it comes to patients who shouldn't receive ADCs, is it very much more about just the normal things, performance status, and worries about whether they'll report the ILD, that kind of thing? Or is it's ADC unless you can think of a good reason not to?
Well, I think if you think about what drives toxicity to ADCs, then it's some classic chemotherapy toxicity. So we know how to select patients for that. And there's some antibody-mediated toxicities, such as cardiotoxicity with HER2 targeted agents. And then there's some ADC-specific toxicity, such as ILD, as you mentioned. And we've learned quite well how to select patients. And I think the only maybe slightly newer thing is if someone has a history of interstitial lung problems or pneumonitis, they're probably not great candidates for an ADC that has an ILD risk. But I think I would like to bring a totally different view into this, which is, of course, slightly controversial. But the question is whether we're doing this in the most clever way. For me, it's becoming clearer and clearer that we have one very good shot with a topo-1 payload ADC. And at the moment, we say the target expression is not relevant because, as we saw with the sacituzumab govitecan data, even with low expression, it's still better than chemotherapy. But what if we compare different ADCs? And is there a role, for example, in the future to test the expression of the key targets? And if you have a patient with ultra low HER2, but very high TROP2, is this a patient where we would prioritize a TROP2 ADC over a HER2 ADC or vice versa? We, of course, haven't got data, but it is maybe something we need to think about in the future. If we have one very effective topo-1 ADC, that we possibly choose that by the best expression, most stable expression as well, to give patients the optimal benefit.
The first bite of the apple is probably going to be the biggest. Giuseppe, any closing thoughts?
But since we are moving with ADC in the first line setting, we saw the data of Destiny 9 in combination with pertuzumab, but we will see the data of Destiny 11 in the neoadjuvant setting. And then we saw the data in the triple negative disease. So personally, I believe it will be really essential to perform more biopsy in clinical trials to better understand which are the mechanisms of resistance and eventually which are the features that may predict better a response to ADC. So in the future, I see the ADC positioned in the early line setting, and what will be challenging is to do what to do after, because we don't have absolutely data on that setting.
So lots of challenges, but we should not bemoan the challenges because it is the wealth of data and the wealth of positive data that we have available that is causing all the head scratching. So I think lots of food for thought and lots of data still to come, but actually a very exciting time when we actually have really good options for our patients. So it's just about finessing how to best use them. So I would like to just draw this session to a close and end by thanking my fantastic panel. Giuseppe, Peter, thank you for joining me for this important discussion on the use of antibody-drug conjugates in metastatic breast cancer. And thank you to everyone who's watching for your attention during this activity. We really hope this information will help you implement best practice using ADCs in your own clinical practice. Thank you.